I found this quite a difficult talk to prepare because it was such a big topic. And so I've decided to cover vaccine in pregnancy and age-related vaccine in healthy people. And I'm not going to cover travel medicine, travel vaccines, employment-related vaccines, or high-risk individuals. So I apologize for not being a complete coverage, but the talk's going to take long enough as it is. But I have to declare a conflict of interest. Medicines New Zealand are paying me an honorarium for preparing and giving this talk, and over the years I've had tons of support from vaccine companies and other organizations, and so you have to bear that in mind when weighing up the significance of any statements I make. In this talk I'm going to cover just first immunosenescence. As we all know, nothing works quite as well as you get older, and this includes response to vaccines. We're used to childhood vaccines having very high efficacy, 90–95%, but we actually use a lot of vaccines in adults that have efficacies of 40 or 60%, and that's because the immune system doesn't respond as well as one gets over. When I was preparing the talk, I had a look at some demographic data from New Zealand, and it's quite interesting, and so I've got one or two slides on that. And then I'll cover vaccines in pregnancy, which I think are very important, 18 to 20-year-olds, 20 to 64-year-olds, and over 64-year-olds. And the vaccines that are listed there are the ones I'm going to concentrate on, because I found I've either been asked questions about those vaccines in this context, or there are things that I'm quite interested in. But firstly, I'd like to congratulate you all. There's been a dramatic improvement in New Zealand immunization coverage since 1992, when it was first measured, and we're now at 94%. We've still got a little bit of work to do with on-time coverage, but this is a very great improvement, and we're now doing at least as well as Australia, and I had some Australian colleagues recently thinking that we were doing better than them, and Australia does extremely well with immunization. So that's all down to you folks who've done a great job on this. Just looking at the immunization coverage at the end of last year, at 8 months we were at 94%, which is great. It would be nice to get that 94% back to 6 months and perhaps get it up to 95%. At 18 months, we're at 85%, 2 years at 94%, which is great, but it would be nice to get that 94% back to 16 months. And there's still a bit of work to do on the 5-year coverage, but this is a dramatic improvement what it used to be, and it's all down to general practice and practice nurses, so well done. So just moving on to demographics, this is from Statistics New Zealand, the projection of the New Zealand population, and you can see that we're expecting the population to increase by about 1.2 million over the next 30 years or so, and births are going to plateau at about 63,000 or thereabouts, but deaths are going to drop dramatically to a third of what they are now by 2048, and I found this quite a striking figure. I wasn't quite sure whether to really believe it or not, but these are the projections they made. I presume it's because the life expectancy of people born in the 70s and 80s is considerably more than the life expectancies born in the 40s and 50s. I don't know, and I don't know how much the obesity epidemic has been taken into account by this. So the rest of the data looks at the percentages of the population, and you can see that the percentage at 0 to 14 declines from 20% to about 16%. There's a 5% drop in the 15 to 64-year-olds. There's close to a doubling of those aged greater than 64 and a trebling of those aged greater than 84. So the burden of elderly people in the population, and I kind of use that term slightly loosely, elderly greater than 65, which is how it's generally used, but being nearly 66 myself, I find it a little bit concerning. But there's going to be a significant burden on the health community, potentially, of all these older people who are coming into the community, that we're going to have to do all the prevention we can get, including vaccination. This is just a slide that I came across. 2,000 turned 65 every day in the UK and 11,000 in the US, and I extrapolated that simply on population figures. So there's about 150 people who become 65 every day in New Zealand. And this data from the UK about the number of workers supporting elderly greater than 65 is quite dramatic in the way it falls from 12 to 4 over the century. So these are quite concerning statistics in terms of what we're going to have to cope with in healthcare, and I think it just emphasizes the importance of prevention. So I'm now going to move on to talk about lifelong vaccination under these 4 different categories. And firstly, pregnancy. In every pregnancy, you should give influenza vaccine if the pregnant woman is going to be pregnant during the influenza season. And this is because influenza can be quite a severe disease in pregnancy. So that's probably about 3/4 of pregnancy to which this should apply. It's generally given from the second trimester, but you can give it in the first trimester if they're going to be in the first trimester during the influenza season. And I've recently given influenza vaccine to 2 women who presented and were about 6 weeks or so. So you shouldn't hesitate to do that because it's regarded as being a very safe vaccine in pregnancy. Tetanus, diphtheria, and acellular pertussis vaccine should be given in all pregnancies between 28 and 38 weeks. There are 2 reasons for this. The first is that babies catch pertussis from someone, and when it's been studied and when the source has been found, in about 50% of the cases of infant pertussis, the mother is the source of infection. So it's important that women are immune to pertussis at the time of delivery. The other issue is the timing of giving it between 28 and 38 weeks. When you give the dose of acellular pertussis, you get a boost in serological immunity, and some of that antibody can cross the placental barrier. But the drop-off in antibodies is relatively rapid. So if you give the vaccine in early pregnancy, the increase in titer has declined to what it was previously. So that's why you give it late in pregnancy. And there's some data from the UK that suggests this approach is a very effective way of reducing pertussis in infants. And it's given in every pregnancy, irrespective of, even if it's only 18 months since the previous dose. So looking at 18 to 20-year-olds, perhaps the most important thing is catch-up, MMR, hepatitis B, and Tdap. I'll cover my opinions on meningococcal vaccine and HPV in the next section. Varicella, I would offer to anyone who's got no history of varicella and who has had a serological test to suggest that they were still susceptible, and I'd give influenza to anyone at high risk, but anyone who asks for it, I'd be very happy to give influenza to. Meningococcal vaccine is recommended for adolescents and young adults who are going to be in communal living, such as university hostels, boarding schools, prison, or the military. So we're really thinking, I guess, about people going to live in university hostels. And so the question is, which vaccine? Now, this is the meningococcal data from New Zealand in 2014, and there were 46 cases. Now, 15 years ago, we had 400 cases, and the peak epidemic year, it was just about 600. So the situation now is far better than it was in around about 2000. So the predominant group is still Group B. There's no Group B vaccine licensed in New Zealand. There is one in Australia, and it's got 4 antigens in it, including the New Zealand epidemic antigen, but it's not yet licensed in New Zealand. And when it is, there'll have to be some consideration of whether it should be used or not. Essentially, what we're talking about here is Group C and perhaps Group Y, which tend to cause more disease in adolescents and young adults, whereas the B tends to be a bit more in young infants. So which vaccine should you use? We've got Group C conjugate vaccines and we've got ACYW conjugate vaccines. This is the data from 2013. It wasn't available for 2014 when I prepared this talk. And you can see in this column here, there were 5 cases in 2013 in this age group that could have been prevented by Group C conjugate, and 7 cases that could have been prevented by the quadrivalent conjugate. 5 of them, of course, Group C as well. When I've been asked in the past which vaccine we should give young adults going to university, I've generally said Group C because that's the bulk of the risk, and that's still a reasonable answer. I'm feeling a bit more inclined to suggest they should have the quadrivalent vaccine now, but either would be okay. So the next thing I want to appeal for is to make HP vaccine available for males, in other words, that it becomes universal. And the rationale for this is in this slide. Now, down the bottom is the number of genital warts caused by HPV. This is the amount of cervical cancer caused by HPV, and this is worldwide data. This is not New Zealand. There aren't 570,000 cases of cervical cancer in New Zealand. But the bulk of these cancers occur in countries with no screening program, and the amount of cancers that occur in screening programs would be much, much less. When you look above the line at the other cancers caused by HPV, you've got approximately just under 50,000 male cancers and just under 50,000 female cancers. So the number of cancers that occur once you've excluded cervical, and a lot of that's dealt with by the screening program, are about equal, male and female. And I would be happy to offer HPV vaccine to any young male. I would like to see HPV vaccine as a gender-neutral vaccine given at 9 to 15-year-olds. And I think that will happen. I think it's just a question of time when it does happen. And there's now a 9-valent HPV vaccine that's becoming available. It's licensed in Australia, it's licensed in the US, and it's likely to be licensed here soon. And that would prevent about 90% of all these cancers, and it seems to be an extremely effective vaccine that gives stable protection for at least 10 years and probably longer. So I think male HPV vaccine should be encouraged. Moving on to 20 to 64-year-olds, Tdap I would offer to anyone particularly who was likely to be exposed to young children, influenza to anyone at risk and anyone who wanted it. I would offer HPV to adults, males up to the age of 26, females older who requested it, or particularly females who'd had cervical abnormalities. I think it's reasonable to offer them the vaccine because at least they'll be protected from the sorts against which they haven't already been infected. And that argument will become stronger once we've got the 9-valent vaccine available. Hepatitis A vaccine should be offered to people with hepatitis infected already with hepatitis B and hepatitis C if they've been exposed in the community, and it's a travel and employment vaccine. Zostavax is licensed from age 50, but I would generally encourage it from age 60 rather than from age 50. I just want to spend a little bit of time on varicella. I was asked in this situation, 42-year-old male with no history of chickenpox, and his daughter had chickenpox. Should he be vaccinated? And I said, oh, he's probably immune. I think we should get a blood test done. And about 2.5 weeks later, he turned up in my consulting room with quite a severe attack of chickenpox, and he required acyclovir. He was off work for a week, took probably about 10 days to a fortnight to fully recover. So he had quite a severe attack of chickenpox. And this made me reconsider what my advice should have been. So this is my rationale for saying that we should have done a blood test. Varicella occurs worldwide and affects both sexes and all races. It's highly contagious and infects at least 90% of the population. The acquisition is a bit slower in tropical countries, but it's in temperate countries it's fairly rapid. And in New Zealand we expect about 90% to be infected by age 14 and 97% by age 40. So varicella exposure age 42, 97% immune by age 40, and 75 to 90% of those with no history you'd expect to be immune. And there's some evidence that the vaccine protects if it's given within 3 and possibly 5 days of exposure, but of course it will protect against future exposures. So in this scenario, what are the options? Do nothing, which is effectively what I did this time. You could blood test and vaccinate if negative. The problem with that approach is that it inevitably leads to delay in delivering the vaccine, and so you may end up with a situation that I did, which was essentially doing nothing. Or you could vaccinate and do a blood test simultaneously and give the second dose only if the blood test indicated there was seronegative, or you could just simply give 2 doses, 28 days apart. My inclination is to go with vaccinate and blood test simultaneously, though I'd talk it over in more detail with the patient now and give them that sort of choice. I think the third option of vaccinate and blood testing simultaneously and omitting the second dose if they're already immune is probably the best approach. So moving on to 65 plus years, which is in some ways the most important consideration with adult vaccination, we've got tetanus, diphtheria, acellular pertussis vaccine, again if they're going to be exposed to young infants. We all use influenza vaccine a lot. In fact, New Zealand's giving a lot of influenza vaccine and doing very well, and we really don't hesitate to use this vaccine. But what sort of levels of efficacy can we expect? Well, I mean, there's tons of data on this, and I just picked this from a CDC document, the MMWR, that was a sort of review of influenza efficacy. And you can see that in controlled trials, the efficacy is round about 60%. It's lower for nursing home residents, who are presumably sicker and whose immune systems are even more senescent, and so they probably don't respond as well. But in terms of influenza-related death, the efficacy is a bit higher. When you look at hospitalization, there are variable reported efficacies. And I've included the statement on non-controlled studies because there were quite a lot of studies done a number of years ago that looked at people who'd been vaccinated and those who hadn't, and they indicated that there was a reduction in hospitalization and death by vaccination, but these weren't randomized controlled trials, so they may have been confounding issues. For example, you may have only vaccinated the healthy people. So my point here is that this is a vaccine that's widely used, that we don't hesitate to use, that we're strongly encouraged to use, but the efficacy is only about 60% in the elderly, but that's fine. So moving on now to shingles. This slide shows you the country-specific rates for shingles from about 8-9 different sources, and they're all broadly similar, with increasing as age increases. And when you get up to 80, you've got rates of about 10 or thereabouts to about 14, perhaps up to 16 per 1,000 per annum, which is the traditional way of measuring zoster rates, the number of cases per 1,000 people per annum. There was no data available in New Zealand until we did a study in our practice. It was a retrospective chart review study, and we were pretty strict about what we counted as cases. And we ended up with a population rate of about 3 per 1,000 per annum, which fits reasonably well with international data. 70% of the cases occurred in those aged greater than 50 years. Females had a higher rate than males. And when we got up to 80 years, the rate was about 14 per 1,000 per annum. And this is pretty well consistent with international data. I would suggest that it would be reasonable to extrapolate these rates to the rest of the New Zealand population. Others may disagree with me. But I think we have roughly the same rate in New Zealand as has been reported internationally. And it's getting worse. There's recent Australian data where they examined the rate in 60-plus-year-olds between 2 time periods, 2000 and 2006, compared with 2006 to 2013. And they used 2 sources of data, GP data and prescription data. Now, they didn't give the same results, but they did show an increasing trend of rates of disease. These rates are actually quite high for 60 pluses, and I suspect there's some imprecision in this, but nevertheless, using the same methodology for 2 time periods, both data sets showed an increase in rates. And this has also been seen in the States. If you look at this line, this is all over 65, and this is 1992 to 2010, almost a 20-year period. You can see rising rates from about 10 per 1,000 per annum to about 13 to 14 per 1,000 per annum. We don't really understand why these rates are rising, but they do seem to be definitely increasing a little bit over time. So this is a very good example of immunosenescence with zoster vaccine. And you can see here that the efficacy at 50 to 59 is 70%, 60 to 69 is 64%, 70 to 79, 41%, and over 80, 18%. That's efficacy against herpes zoster itself. When you look, however, at postherpetic neuralgia, which is perhaps one of the most important things to ameliorate or stop, the efficacy at 60 to 69 was 66. It went up, actually, at 70 to 79. It fell a bit in the over 80s, but not down to 18%. It wasn't measured in the 50 to 59-year-old age group because it's relatively unusual in that age group. So this raises the hypothesis that the zoster vaccine may preserve quality of life without presenting infection. And this has been studied as well. A scoring system was developed for loss of activity, including duration of activity. And as you can see in the placebo group, as you age, you get a greater score for loss of activity. This also happens in the treated group. There's an increase in loss of activity as you age. But when you look at the efficacy for prevention of loss of activity, there is not a huge decline in efficacy in these different age groups. There's a little bit of a decline, but not a huge decline. So my argument is that it's still worthwhile using zoster vaccine even in greater than 80-year-olds. So how common are second episodes of zoster? Well, there's relatively scarce data on this. There's small populations and short follow-up periods, but a relatively recent study shows a 6.2 recurrence rate over 8 years. So it would probably be 8 to maybe 10% over 10 years. And recurrences are more likely in women, the immune compromised, and those with prolonged pain at the initial episode. So I was asked this question again. A lady aged 68 who 6 months ago had an attack of ophthalmic shingles wants to avoid another attack and requests vaccine. When should it be given? Well, there's no clear answer to this question. The Australian authorities and the Canadian authorities say you should wait a year. The American authorities don't say anything about it. And I've spoken to a number of international experts on this, and you'd never get an absolutely consistent answer. So, but one of them, who I've got most faith in, says about 1 to 3 years, and that seems to make a reasonable amount of sense to me. So what I would do is, if it was a very severe attack, I would tend to go closer to 1 year, or if it was someone who had an immunocompromising condition that didn't amount to a contraindication to the vaccine, I'd go closer to the 1 year. If it was someone healthy and the attack wasn't too severe, then I'd go closer to 3 years. That may change as more data becomes available. There is a new piece of information that's recently come out about the GSK shingles vaccine, and this was published really very recently, only a couple of months ago. It's an inactivated vaccine given as 2 doses. It was studied in a randomized controlled trial in adults greater than 50, and it gave really quite a high level of efficacy of 97% that was stable across age groups. Now, if this turns out to be real, and it seems to be, then this is potentially very promising in terms of shingles prevention. And its disadvantage is that it's got 2 injections, and it's quite reactogenic, including about 17% in the vaccine group who got type 3 events which involved with interference of activity. And remember, this is 2 doses, so there may be a higher efficacy but a trade-off with greater reactogenicity. It's very much watch this space and see what happens with this vaccine. So moving on to pneumococcal vaccine, which is currently recommended in the Immunization Handbook as pneumococcal conjugate vaccine 13, Prevnar 13, followed at least 8 weeks later by the polysaccharide vaccine that's been around for years. This is recommended but not funded. And the whole area of pneumococcal vaccination over 65 and healthy over 65 seems to be extremely controversial. So I'll try and make some sort of sense of it. So this is the invasive pneumococcal disease in New Zealand for March 2015 report. It's the most recent one I could get when I prepared the talk. And you can see that the rates in the under 2s are broadly similar to the rates in the greater than 64s. A little bit more of a difference in the number in March 2014 data, but the number of cases is much higher in this greater than 64-year-old age group, obviously because the population group's higher. So the potential to prevent a larger number of cases exists in the greater than 65-year-old age group. Of course, the under 2s are helped considerably by already receiving vaccine. Again, this is from the ESR annual report in 2013, and for those greater than 64 years, the invasive pneumococcal disease has reduced by about 30% from 2009 to 2013. The reason I've taken 2009, vaccine started in 2008 rather than 2006, is because it was lab data reporting prior to that. This is notification data, and it's just trying to compare like with like. When you look at the lab data, there's been a 75% reduction in invasive pneumococcal disease caused by PCV7, Prevnar 7 serotypes since 2006-2007. And now 81% of invasive pneumococcal disease is caused by non-PCV7 serotypes. So that means PCV7 we've essentially been using since 2008, although we've added some other antigens in. So that means if one of the best protections for adults, particularly those greater than 65, is to make sure that their infants are vaccinated as well. So from non-PCV10 serotypes, 69% is caused by non-PCV10 serotypes in adults greater than 64 years, and 48% caused by non-PCV13 serotypes. So what should happen now that we're using PCV13 routinely with infants is that the percentage caused by non-PCV13 serotypes should rise hopefully to 80, maybe 90% or thereabouts. So in preventing invasive pneumococcal disease in those aged 65 and older, one of the most important things to do is ensure good coverage with children, which is what we're already doing. So looking at the efficacy of pneumococcal polysaccharide vaccine, it's been subject of much debate, and and there's tons of slides I could have done on this, but I've taken this from a Cochrane collaboration, and it shows an efficacy against invasive pneumococcal disease of about 75%, and an efficacy of presenting all-cause pneumonia of about 25%. The conclusion I've tried to summarize about the polysaccharide vaccine efficacy is this, and there's general agreement that efficacy has been demonstrated against invasive pneumococcal disease. There's been variable reported efficacy against pneumonia, and the Cochrane review did consider that efficacy against pneumonia is not proven. The efficacy in adults with chronic illness has not been defined, and there are some experts, Fedson et al., who consider that the prevention of invasive pneumococcal disease alone is sufficient reason for vaccinating all elderly adults with pneumococcal polysaccharide vaccine. When we get on to looking at the efficacy in adults of Prevnar 13, this has been studied in a large randomized controlled trial in the Netherlands with 85,000 subjects followed for about 5 years. And the efficacy against invasive pneumococcal disease was about 75%, which is similar to the polysaccharide vaccine. The efficacy against PCV13 type pneumonia was 45.6%. So this is an efficacious vaccine in the sort of levels of efficacy that we're used to seeing with adults. So what do I recommend to patients? Well, for those age 64 who can afford it, I would recommend PCV13, the Prevnar 13, followed by Pneumovax 23. And my wife and I both had that last year at some stage. But this costs $350, $400, so it's quite expensive, and you have to question whether it's really worth that amount of money. For those who cannot afford it, I think the pneumococcal polysaccharide vaccine would be a perfectly reasonable thing to do. And when the incidence of invasive pneumococcal disease caused by non-PCV13 serotypes it begins to climb, so that you get 80 or 90% of IPD in the elderly group caused by non-PCV13 serotypes, I think the argument for just giving the polysaccharide vaccine will strengthen. I think this is a very controversial area, and I'm not strongly recommending use of this, but I think for people who can afford it, I think it's well worth considering. Now, when you get instructions for these talks, the organizers of this group say you've got to produce 5 key get-home messages, so I've tried to do this. Vaccination is lifelong. Adults need vaccine too. The increasing number of elderly in the population requires all the prevention we can give them, including vaccines, some of which have relatively modest efficacy. Influenza and Tdap vaccines are important in pregnancy, very important, and should be administered. Males should have HPV vaccine, and shingles vaccine can reduce severity of shingles even in those aged greater than 85. And that's the end. Thank you. And most of you coming from the South Island should be able to identify this. It's Wanaka. It's a very beautiful lake.